In India, there are very few ortho-oncologists compared to other specialists. I think when I was getting trained, I was ninth or 10th in the country. There were very few people, I mean, dedicated ortho-oncologists. As such, nobody leaves, like you said, that if bone tumor comes to orthopedician, of course, they will operate. They will take the help of oncosurgeons and do. But what happens if you are not properly trained? Nobody takes complete accountability. A surgeon will do his part, the orthopedician will just put the implant. But as an ortho-oncologist, you are exposed to not just about the reconstruction, but the principles of oncological management. So, what the training is about, ortho-onco training. So, orthopedic oncology training is not just about enhancing your surgical skills, it is much more beyond. It requires a lot of understanding of the theoretical concepts because these concepts are not taught to us in our orthopedic practice. So, the most important thing is what I have uh, seen in my practice. We learn, we unlearn, and then relearn. What does it mean? Of course, in orthopedic residency, we learn how to do things. But once you move to ortho-onco, you have to unlearn all those things. Like I said, going periosteal, subperiosteal, moving away in the planes where there is no vessel. You have to unlearn and then you have to relearn. You have to learn new techniques, new dissection tools, dissection techniques, so that you can remove the tumor completely with wide margins. So the first part is in ortho-onco training is understanding your oncological principles. It is a broad specialty, oncology. And but you need to understand everything like about it's not just about, orthonc is just about you get a patient with giant cell tumor and you operate. You get a patient with osteosarcoma, somebody will chemotherapy and you operate. No. You should be aware of the histology, what type of tumor it is. There are more than 100 types of sarcomas. You need to understand the grade of the tumor. You need to understand about the systemic therapy. Systemic therapy means what you give to in the body to control the extent of the disease in the body, like chemotherapy, immunotherapy, targeted therapies. Uh, you need to know about the surgical techniques. You need to understand the radiation philosophy, radiation therapy philosophy. As an orthopedic oncologist, you are going to be the team leader. If a sarcoma patient comes to you, it is not that somebody else will treat it. As a team leader, it is going to be a multidisciplinary approach. Multidisciplinary approach. So all these specialists, and one more very important is radiology. So you don't just depend on radiologist. You see things yourself. You have to start reading X-ray, MRI yourself. This was something new. So during my orthopedic, yes, I was good in reading X-rays. I was good in reading CT scan, not so good in MRI. So it required a learning phase. And this learning phase compared to all other subspecialties. Let's see what can be the other subspecialties in orthopedics. Arthroplasty, trauma, spine, sports medicine, then your foot and ankle, hand and microvascular. Anything else I missed out? Ortho-oncology. Almost, I think, broadly, people are into this. Yeah, pediatrics is one more important. Pediatric orthopedics. So these are now mostly a specialty which was once considered an end branch is no more an end branch. And why it is important when that you choose one of it. So see, ultimately the outcomes vary. When you focus yourself on one specialty and you deep dive, you are going to improve and refine your skills. Your outcomes will be better. And especially if you are in a tier, metro city something, it is going to be a specialty work. But as you move far away, you're moving towards periphery, you will have to do everything. So you will have to do trauma also, or joints also, or scopy, whatever your interest. Plus, it depends upon the type of setup where you work. Now we are broadening our discussion, right? We'll come back to orthonco training, but I'm just giving you an overall view. So once you start practicing, you need to see which city you are working, what is the type of work that is done there. Is it a teamwork? Single units are very rare nowadays, especially if you talk about Delhi, Bangalore, or bigger cities. Mostly it's a teamwork. It's a multi specialty, subspecialty department. Spine is different, trauma is different, like that. But if you're in a smaller B town cities, like Kanpur, Bareilly, you have to tackle everything, whatever comes to you. You cannot just focus on this because many complex cases are transferred outside. They themselves go outside. Some retain. So you can't be chooser every time unless you have built up your brand, your name, which is difficult in first uh, 3 to 5 years of yours starting your practice. It takes some time to develop your practice. Once your name is there, your brand is there, of course, you can then choose what you like. But till then, you need to practice a broad specialty. So, the ortho training, which I was saying, involves your oncological understanding, oncological principles you should be aware, which includes everything related to it, your histology, your chemotherapy and all, surgical radiation, radiology, etc., etc. So it's a broad training. Second, so oncological will give you an edge, like how are you going to deal with it. Then comes your surgical aspect, the skill training. In skills, especially in orthopedic oncology, you need to learn, different principles of orthopedics, and not just orthopedic. It is about ortho. You have to know about arthroplasty because all limb saving surgeries with mega prosthesis requires special implants or procedures which are called tumor prosthesis. And then you need to know about plastic and reconstructive surgeries. Probably I'll say the only specialty which I don't feel, I mean, I was not trained and I don't feel is required is arthroscopy. Otherwise, because these are mostly open surgeries. So understanding your orthopedic principles, arthroplasty principles, plastic reconstructive surgeries, and oncological surgical techniques, which is primarily wide excisions. So all these things constitute your skill enhancement. So if somebody knows oncological principles and has got the skill, will he be able to take care of the patients who are presenting to them? It's not that easy. You need to have, you know, an good emotional quotient as a oncologist. Here in ortho-onco, today you are seeing a very fit man who has presented with a back pain, and when you did the X-ray, you saw that there is a big lytic mass in the iliac bone. You do a staging workup and you saw that it has spread to other parts. Stage 4 presentation. The life has completely changed. So you need to really have a calm presence, soothing presence, because the moment somebody hears that they have got cancer, everything starts, hyperstimulation starts, sympathetic drive starts, they're in hyper anxious state. You need to be really empathetic to what is happening with the patient. You have to understand. You should have a good communication skill to counsel them what is exactly required, what we are going to do with, what the prognosis is going to be. And you know all this only after years of training. Like I said, your theoretical principles of all different aspects, your skills, and your uh, own experience, which builds your confidence in handling of these cases. So you also should have the temperament of an peace and calm oncologist. Now, why this is important? It's not only while communicating with the patient. The average limb saving surgery, suppose if I'm operating a distal femur sarcoma, I'm doing a reconstructive surgery, wide excision distal femur, and a reconstruct with, yeah. So if I'm doing a reconstructive surgery, average time now for me takes 2.5 to 3 hours. But when I started my journey initially, it was 6 hours to 7 hours. Now I listen to many of my trainees, those who have started practice, they tell us that it took us 8 hours for one surgery. So I can understand because it takes longer. Your initial dissection, you want to be safe. So you should have also a physical stamina to, endure long duration surgeries. It is not like nailing where you finish up in 30 minutes. We boast, yeah, I can do TKR in 45 minutes, skin to skin, or I can do nailing within 25-30 minutes. I'm good at it. So oncological surgeries are not like that. It is never about the time. It is about the quality and precision to, get complete free margins. So what we deal is primarily quality and precision surgeries. So, like I said, these are long duration surgeries, 4 to 6 hours is average, one surgery. So, while your orthopedic friend, he will be operating 2-3 TKRs, earn much more than you, but you will be in the meantime stuck with only one case and probably will earn lesser than his one TKR also. That is also a possibility in this specialty. I'm not just going to present you everything good and good and good, but I'm going to give you a real picture of what it is really in this practice. Second, you need, a solid multi-speciality team. Like I said, whenever every case requires a dissection of neurovascular bundle, suppose something happens. Now, for me, I'm trained, I can do vascular suturings also, I can do some flaps also. But for those who are new, they will also develop over the time. But till then, if something happens, if there is a vascular injury or something happens, you need to have a vascular surgeon or a plastic surgeon. Many a times patients presents with skin defect, it needs to be covered. So these are surgical thing. But apart from surgical, you need, a multidisciplinary team related to oncology, in which your med-onc, radiation oncologist, your pathologist is very crucial. You can operate only once you have a report, your radiologist. So all these team members constitute, especially IR, interventional radiologist. They are a part of my team. So they are a very crucial part of my team. So only when I work in a, it's a tertiary level corporate setup, it's a referral center. So we have all these facilities, so it's very easy. But if you are not in the main city, not in a tertiary care institute, arranging this team is difficult. So this is about oncological aspect. The second aspect will be related to your surgical. Like I said, apart from that, you may need plastic reconstructive team, vascular team if something happens. And then you also need to have backup infrastructure of blood bank, ICU. When I operate any pelvic case, so usually the routine blood loss sometimes maybe 2 liter, 2.5 liters like that. So our blood bank is already informed, and for me, for this is a routine now. So nobody panics if we see 2 liter, 2.5. That is a routine. Many a times patient also uh, have to be on ventilator for 24 hours after surgery. So you need a good ICU backup also, blood bank, all these facilities are required. So this is a broad overview of starting a department. So I was lucky that when I finished and I came, I was there was nobody. So I took it up as a challenge. I developed this team. I developed our entire team at different centers, and gradually now everybody is tuned. So I don't have to tell anything. Everything, the protocols, the systems, the processes, everything is in a flow. So this saves the time, gives a high-end care to the patients who are in need. For example, suppose if I see a patient today, so I've seen all type of setups because I was trained, at TMH. Then I visit Bihar once every month, Bihar and Ranchi, Patna and Ranchi. So I've seen the setups there also. Those are onco centers, and they have Ayushman schemes. And the center where I practice in Delhi is a totally private hospital, high-end care. So there's a big difference in the type of financial aspects also. We need to see that as well for the patients. So the best part of being in a private is that things are all available all the time. Everything is available, whatever you need. You need OTs, it's there. You need to start chemotherapy, it can be done. But many times you may have patients who are not affordable. So for me, it is a good thing that I can always refer them or attach them to the centers where there are different schemes, government schemes or trust. So since I've traveled entire North India, I know centers where these facilities are available, and I can operate them at my center once the time for surgery comes. So these are the things that we need to see when we start a department after your training. When we talk about the learning curve, which we were discussing, so in my setup we have training of 1 year, but I feel usually you have to work a minimum of 2 year in a high volume center. So currently the person who is with me has worked already for more than this is his second year working with me, and I also have an associate and have a fellowship program. So somebody's put a question, Prashant. I'm interested in onco. When do you think is the best to enter to onco fellowship? Immediate or after some years of experience after PG with any previous? Very good question, Prashant. So I'm coming to that. So actually, I missed that part. Yeah, I directly entered the learning curve. So when to take this fellowship? Guys, see, one thing I'm seeing that the trend is changing. Nowadays, I see people when they enter MBBS, they start thinking of becoming a super specialist. Many times seats are taken, they take radiology when they enter MBBS first year. Or when they come to internship, in my time, I used to operate also during my internships. I used to do some hernia surgery or hydrocele surgery when I was in general surgery posting, or putting all the lines when I was in including ICD lines or CVP lines when I was doing my internal medicine rotational posting during internship. But that scenario has changed now. People don't want to waste that time. They just want to enter into a specialty department as soon as they come out of MBBS. And similarly, even in orthopedic training, what I've seen, everybody is focused like we have to become a joint replacement surgeon or I want to become a spine surgeon. So people start making up their mind when they are during in their residency. But let me give you some very fair and clear ideas. Do your residency and SR ship. senior residency program. So in India, it's for 3 years, and SR is usually for 3 years. So I prefer that you do this properly, dedicate full time, get hands on. The scenario has changed nowadays. So even in residency, I see now people are not much exposed because the number of seats in the faculty is so many that professor does arthroplasty, associate has one table or two table in a week. They do probably some arthroplasty and some scope if they're interested. The assistant professors have one table. So they try to grab whatever comes to their place. And then the SRs, they do the traumas and other things. I'm not talking about any individual institution. It may be varying. Some institution may have a very good setup, but I'm talking broadly what I am seeing because I get feedbacks, a lot of queries from different people from different parts of the country. So when I talk to them, I realize this is the system, how it is. And not two institutes have the same training protocols. At some place, some might be exposed to joint replacement. In other institute, people come out without doing probably uh, even something assisting a joint replacement. So there is a lot of variation in our training in India. So if you are lucky that you are able to get all the exposure, but still, I feel after 3 year residency, do 2 years of at least SRship in all the specialty. What happens? You get biased. It's a very good word, biased. Like during my residency, I was more exposed to trauma. So I wanted to become a trauma surgeon. I liked open wound, big scars, big sutures. So open everything, fix it. But some people, those who have got more training into spine, they become oriented to spine. Some people are more, exposed to scopy. They get interested into scopy. So it also depends upon your exposure during your residency, which finally builds up your interest. So get exposed to everything, your trauma also, your spine, whatever the postings are, do it sincerely. Then only you will realize what is your taste, what do you like, because you're going to live with it for whole life. Joints, yes, people look at joints in a way that it is very straightforward. You earn well, but if you look at it is challenging, but when you assess, sometimes you feel bored that every time it is the same exposure, cut, 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 distal femur, upper tibia, cut, cut, like this. Some things are challenging. Every trauma case may be challenging. Ortho-onco, very, very challenging. Every case is uh, will give you adrenaline rush. So get exposed to all these specialties, see what suits you, what your inner call is, and then you choose it. Without, especially like I told you in ortho-onco, if you want to grasp it during your fellowship, you need to have a prior exposure of trauma, joints, a little plastic surgery that you learn during the training. So I think I answered your question, Prashant, that at least you should wait for 2 years after your MS. Like this is also the criteria on which I choose my fellows. My first fellow was 10-year post MS. Second was almost 5 years. Third was also 7 years post MS. Uh, One was 4 years. So like that, I usually have take more than 3 years. I give them a sincere, advice that don't jump into fellowship immediately. Otherwise, you may come because of interest. But unless you are trained enough, I will not be able to give you independent cases. I will not be confident to give you cases to handle blood vessels or leave, uh, you know, joint reconstructions upon you unless you have done arthroplasty. So get yourself trained in trauma, arthroplasty well, especially if you want to get into ortho-onco. Right. So just to show you how, like I told you about wide margins. So you must have seen this video probably. This was a case of osteosarcoma and upper tibia. So we remove it with wide margins. So what is wide margin? Like I told you how the principles are applied. So when we remove a tumor, we have to apply principles of oncology of removing the tumor with wide margins. Then you have to reconstruct the bone defect. Here you have to apply the principles of arthroplasty or trauma, depending upon how we are reconstructing. Then for soft tissue reconstruction, your plastic reconstruction, all this knowledge which you have gathered helps you in this reconstructive procedure. So this is an interesting case. What is a wide margin? How we remove it? So this was a case of upper tibia tumor, operated 4 times. Fifth time somebody told them that now it will be amputation. The challenge was patient had infection as well as tumor recurrence with a pathological fracture. So we remove, you see, when we remove it with a normal muscle tissue all around. That is the posterior compartment. This is the anterior medial. Here you see the previous skin scar of previous surgeries that is removed. Now, when we move it, not a drop of blood is coming out from that fracture site, from the hematoma which is inside, because it is covered by normal tissue. So this is how we remove a cancer cell so that not a drop of it comes out from where it is. It should be covered with the normal muscles all around, like the posterior compartment muscles, anterolateral muscles. So when we operate like this is called wide margin. Then only, then only our tumor recurrence risk are less. So the reconstruction, if you see, like here we have taken this mega prosthesis, but it is a proximal tibia. This is only subcutaneous. Many of these implants fail. I've seen people, those who are not trained, they just do prosthesis and put the cover back, use some wires tied to the patellar tendon. It doesn't work like that. It fails ultimately. Currently, I have 2 patients who are waiting for revision surgery because it was done like that. So what we should do ideally, we take the gastrocnemius flap. This is the medial gastroc. We cover the implant. We reconstruct the extensor apparatus here. So your patellar tendon is sutured here. So a knee flexor starts acting like a knee extensor. This is how it looks like on the prosthesis. So this guy has a long follow-up now. So I think I discussed this part already. Like you need to have a multidisciplinary team where you can handle all type of cases. These tests usually requires your MRI, CT, PET CT. Of course, you can send it somewhere also and get it done. But if it is good if your center has all these facilities.